For many men, changes in sexual performance do not begin with a dramatic moment. They begin quietly. A person who has never had trouble getting or keeping an erection may start noticing that things feel different. Desire may still be there, affection may still be there, attraction may still be there, yet the body does not respond in the same reliable way. At first, it is easy to brush it off. Maybe it is stress. Maybe it is lack of sleep. Maybe it is getting older. Maybe it is just a bad night. But when it happens again and then again, uncertainty starts to creep in. A man may begin to wonder whether something is wrong with his health, whether he is losing masculinity, or whether his relationship is quietly suffering in ways he cannot explain. What many people do not consider right away is that the answer may be sitting in a pill organizer, a bathroom cabinet, or on the kitchen counter beside breakfast. This is one of the more frustrating truths in medicine. Sometimes the very treatments designed to protect long-term health can unintentionally affect a deeply personal part of daily life. A medication prescribed to control blood pressure, lower cholesterol, reduce the risk of cardiovascular events, or improve blood sugar can be essential for preventing serious disease. Yet that same medication may also contribute to sexual side effects in some individuals. That possibility can feel confusing and even unfair. After all, a person follows medical advice, takes treatment as instructed, and tries to do the responsible thing, only to discover that intimacy has become more difficult. The emotional effect of that experience is often underestimated. Sexual health is not a luxury issue. It is tied to self-confidence, closeness, identity, mood, and overall well-being. In real life, this often shows up in ways that are more human and less dramatic than people imagine. A man in his 50s might start avoiding intimacy because he is afraid of disappointing his partner, even though he has never spoken those fears aloud. Someone newly diagnosed with diabetes may feel relieved to finally have a treatment plan, but a few months later may notice lower desire, weaker erections, or a sense that his body is no longer responding with the same ease. Another person may take a daily medication for years and never connect it to the changes he is experiencing because the shift happened gradually. Instead of suspecting a side effect, he blames age, relationship problems, or a personal failing. That silence can become its own burden. Part of the reason this topic is so important is that erections are not produced by one single organ or one simple switch. They depend on a carefully coordinated conversation between the brain, blood vessels, nerves, hormones, emotions, and the surrounding context of a person's life. Desire starts in the mind but has to be translated into physical signals. Those signals travel through the nervous system. Blood vessels need to widen appropriately so blood can flow into erectile tissue and stay there long enough for firmness to develop. Hormones, especially testosterone, help support sexual interest and the body's readiness to respond. This means that anything interfering with circulation, nerve signaling, hormonal balance, energy level, or emotional state can influence sexual function. Medication side effects become especially relevant because drugs often act directly on one or more of those same systems. That does not mean every medication causes erectile dysfunction, and it certainly does not mean that anyone who develops erection problems should immediately assume the prescription bottle is to blame. The body is more complicated than that. Erectile dysfunction can have many contributing factors, including diabetes, high blood pressure, cardiovascular disease, smoking, sleep apnea, anxiety, depression, relationship strain, alcohol use, obesity, hormonal disorders, and simple exhaustion. In fact, many of the conditions that medications are meant to treat are themselves among the most common causes of erectile difficulties. This is where people understandably get lost. Is the problem coming from the illness, the treatment, or both? Sometimes it is not one clean explanation. Sometimes it is a combination, and teasing that apart requires honest conversation and thoughtful medical evaluation rather than guesswork. Still, recent research has raised an important concern that deserves attention. Large population data have suggested that men taking prescription medications are more likely to report erectile dysfunction than men not taking them, even when researchers account for other health factors that also affect sexual performance. That does not mean every prescription is dangerous to sexual health, but it does reinforce something clinicians have seen in practice for years. Medication-related sexual side effects are real. They are common enough to matter, and they are often underreported because patients feel embarrassed to bring them up. Many people will tell their doctor about headaches, nausea, dizziness, or fatigue without hesitation, but when the side effect involves erections, desire, or orgasm, the conversation often stops before it starts. There is also a powerful myth that tends to make this worse, which is the belief that erectile dysfunction is simply an unavoidable part of getting older and therefore not worth discussing. Age can certainly affect sexual response, But erection problems should never be dismissed as meaningless. They can reflect medication effects, but they can also serve as an early signal of broader health issues, especially those involving blood vessels. The arteries supplying the penis are small, and changes in circulation may show up there before larger cardiovascular problems become obvious elsewhere. In other words, the bedroom can sometimes reveal what the heart and blood vessels are struggling with long before a person experiences a major event like chest pain or a stroke. That is one reason sexual symptoms deserve medical attention rather than quiet resignation. Another myth is that if a medication may be contributing to erectile dysfunction, the solution is to stop taking it immediately. That is not only incorrect but potentially dangerous. Medicines used for high blood pressure, cholesterol disorders, diabetes, and heart protection are often preventing life-altering complications. Stopping them without medical guidance can place a person at far greater risk than the sexual side effect itself. The wiser and safer approach is not panic, it is curiosity, it is asking better questions. It is recognizing that a side effect does not have to become a secret and that treatment plans can often be adjusted. Sometimes the answer is switching to a different drug in the same class. Sometimes it is changing the dose, rethinking the schedule, addressing another health issue in parallel, or supporting sexual function in additional ways, but none of that can happen until the problem is acknowledged. What makes this conversation so meaningful is that it sits at the intersection of physical health and private life. A man may love his partner, want intimacy, and care deeply about staying healthy, yet still feel caught between those priorities. He may worry that speaking up will sound vain, weak, or trivial compared with conditions like diabetes or heart disease. In reality, bringing up sexual side effects is not selfish. It is part of complete care. Sexual well-being is woven into quality of life, and doctors need accurate information to help patients choose the best overall treatment path. So the real question is not whether health should come before sex or whether sex should come before health. That is a false choice. The more useful question is how to protect both. Understanding that medications can sometimes interfere with erections is the first step. It allows men to stop blaming themselves, stop assuming they are alone, and stop making silent compromises that erode confidence and closeness over time. It also opens the door to a broader truth that will guide the rest of this discussion. Erection problems are rarely random, often understandable, and almost always worth exploring with care, patience, and evidence rather than shame. Begins with a simple but important idea that an erection is not just a sexual event. It is a vascular event, a nerve event, a hormonal event, and in many cases, an emotional event all at once. That is why erectile dysfunction can never be reduced to a single explanation. When a man becomes sexually aroused, the brain interprets physical touch, visual cues, emotional connection, fantasy, memory, or desire, and sends signals through the nervous system. Those signals tell blood vessels in the penis to relax and widen. Blood then flows in, the tissue expands, and pressure builds in a way that allows firmness to develop and be maintained. This process sounds straightforward when described in a textbook, but in real life it depends on many body systems working together smoothly. If circulation is impaired, if nerve communication is dulled, if hormone levels are disrupted, or if the body is under persistent physiologic strain, erections may become weaker, slower, or less reliable. This is where medications enter the picture. Most drugs do not affect sexual function in exactly the same way. Some influence blood flow by changing how blood vessels constrict or relax. Others act on the brain or nervous system and can interfere with the signaling needed for sexual arousal and response. Some alter hormone production indirectly, which may reduce libido and make erections harder to initiate. In certain cases, the medication itself may not be the only problem, but may add another layer to an already vulnerable system. A man with diabetes, mild vascular disease, poor sleep, and chronic stress may still function reasonably well, but once a medication with sexual side effects is introduced, the balance may shift enough for symptoms to become noticeable. That does not mean the medicine is bad. It means the body often operates with a limited reserve, and small disruptions can matter. One of the most commonly discussed medication groups in this context is the beta blocker family, especially drugs like atenolol. These medicines are often prescribed for high blood pressure, heart rhythm problems, and certain cardiovascular conditions because they reduce strain on the heart and help control the body's stress-driven fight or flight responses. For many patients, they are valuable and appropriate, but the same calming effect on the cardiovascular system can sometimes contribute to erection problems. Since an erection depends on healthy blood vessel relaxation and adequate blood delivery, anything that reduces circulatory responsiveness may make the process less efficient. Some men on beta blockers describe a lower level of sexual confidence rather than a total loss of function. They may still get erections, but they're less predictable, less firm, or harder to maintain. Others may notice reduced energy or a subtle sense of emotional flattening, which can also influence desire and performance. The point is not that atenol inevitably causes erectile dysfunction, but that it can be part of the picture for some men and deserves consideration when symptoms arise after treatment begins. Cholesterol-lowering medications, especially statins such as simvastatin and atorvastatin, create a more complicated discussion because they illustrate how medicine can help and potentially hinder at the same time. On one hand, unhealthy cholesterol levels contribute to atherosclerosis, the gradual narrowing and stiffening of arteries. Since erectile function relies heavily on good blood flow, treating cholesterol problems can protect long-term sexual health by preserving vascular health. On the other hand, cholesterol is also a raw material used by the body to make steroid hormones, including testosterone. In theory, sharply lowering cholesterol could affect hormone production in susceptible individuals, particularly at higher doses or in men who are already hormonally borderline. This does not appear to happen in most patients, and many men take statins without any sexual side effects at all. Still, if someone starts a statin and later notices lower libido, diminished energy, less morning erection activity, or new erectile symptoms, it may be reasonable to evaluate testosterone and consider whether the treatment plan should be adjusted. This should be done medically, not by self-diagnosis, and not by abandoning a drug that may be reducing the risk of heart attack or stroke. Aspirin tends to surprise people because it is familiar, inexpensive, and often seen as too ordinary to have meaningful sexual consequences. Yet common medications can still have complex effects. Aspirin influences platelet activity and inflammatory pathways and may also affect nitric oxide signaling under certain circumstances. Nitric oxide is essential for erections because it helps blood vessels relax and allows the erectile tissue to fill effectively. If that signaling is disrupted, erection quality may suffer. That said, this is not a reason for panic. Daily aspirin is often taken for specific cardiovascular reasons, and in many cases, the benefit clearly outweighs any possible sexual downside. The more useful lesson is that the counter does not mean biologically neutral. Medications that seem routine can still influence the body in subtle ways, especially when used chronically. Metformin introduces another layer of complexity because it is one of the most commonly prescribed treatments for type 2 diabetes, and diabetes itself is one of the strongest predictors of erectile dysfunction. High blood sugar damages blood vessels and nerves over time, both of which are central to sexual response. Many men with diabetes experience erectile difficulties not because of a single bad week or one medication, but because years of metabolic strain have gradually affected the systems required for normal function. Metformin is often beneficial because it improves insulin sensitivity and helps control blood glucose, which may protect long-term health. However, in some individuals, it may contribute to lower vitamin B12 levels over time, and that matters because B12 helps support nerve health. If nerves are already vulnerable, reduced B12 may worsen tingling, numbness, fatigue, or neurologic symptoms, and in theory, it may also influence sexual response. Some research has also raised questions about whether metformin may affect testosterone in certain men. Again, this does not make metformin a harmful drug overall. It means that if a man with diabetes is experiencing erectile dysfunction, the conversation should include not only blood sugar control, but also medications, nutrient levels, hormones, vascular health, and nerve function. What patients often need most at this stage is reassurance that erectile dysfunction is rarely a personal failure. It is a symptom. Sometimes it is an early clue. Sometimes it is a side effect. Sometimes it is a consequence of the very disease being treated. A man with untreated high blood pressure may develop erection problems because years of elevated pressure damage delicate blood vessels. A man with uncontrolled cholesterol may have reduced penile blood flow because plaque is building up in the arteries. A man with poorly managed diabetes may have injury to the tiny nerves and vessels needed for sexual response. In that sense, the medications and the conditions they treat are locked in a difficult relationship. The disease may harm erections, the treatment may occasionally influence erections, and the patient is left caught in the middle, unsure whom to blame. That is why broad, simplistic advice is so unhelpful. The question is not, is it the pill or is it the disease? The better question is, what is happening in this particular person? And how can we improve both health and sexual function safely? A careful medical approach usually includes more than reviewing prescriptions. It may involve checking blood pressure control, blood sugar levels, cholesterol patterns, sleep quality, alcohol use, smoking status, weight changes, mood, energy, and hormone levels. Testosterone testing can be useful when symptoms include low libido, reduced morning erections, fatigue, reduced muscle mass, or declining motivation. Vitamin deficiencies may also matter, especially in men taking long-term medications known to affect absorption. Sometimes the evaluation reveals that erectile dysfunction is the first visible sign of a broader cardiovascular issue that had not yet been fully appreciated. This is one reason doctors often take sexual symptoms seriously even when patients feel embarrassed bringing them up. In some cases, the penis acts as an early warning system because its blood vessels are smaller and more sensitive to circulatory problems than larger arteries elsewhere in the body. Patients also deserve clear, practical honesty about treatment. There is no single perfect medication that works for everyone without trade-offs. Medicine is often about balance. A doctor may choose one drug because it is best for heart protection, another because it is safest with kidney disease, another because it helps with blood pressure and migraine prevention, and another because it is affordable or well tolerated. Sexual side effects are part of that balancing act and should be openly discussed rather than treated as an afterthought. Some men do better after switching from one blood pressure medication class to another. Some improve when a dose is reduced appropriately. Some benefit from treating low testosterone, correcting B12 deficiency, managing sleep apnea, or improving diabetes control. Others need direct erectile dysfunction treatment in addition to addressing underlying causes. The most important point is that there are often options. By the end of this medical discussion, what should become clear is that erectile dysfunction is not just about sex and not just about medication. It is about the body's overall condition. It is about circulation, nerves, hormones, inflammation, and how chronic disease shows up in everyday life. Medications can contribute, yes, but they do so within a larger health story. Understanding that bigger picture helps remove blame and replace it with strategy. And once the problem is understood that way, the next step becomes much more hopeful. Not simply identifying causes, but deciding what a man can actually do day by day to protect both his health and his intimate life without feeling forced to sacrifice one for the other, is where this conversation becomes less about fear and more about direction. Because once a man understands that erectile dysfunction may be connected to medication, underlying health conditions, or both, the next question is naturally what to do about it in real life. The first and most important step is to stop treating the problem as something too embarrassing to mention. Many men delay the conversation for months or even years. They may talk themselves into believing it will pass, that it is just stress, that it is not serious enough to justify a doctor's visit, or that discussing it will somehow seem trivial compared with diabetes, blood pressure, or heart disease. In truth, the opposite is usually true. Sexual symptoms are often medically useful. They can reveal how the vascular system is functioning, whether hormones may be changing, whether chronic illness is well controlled, and whether treatment side effects are interfering with quality of life. A person does not become shallow by caring about sexual health. He becomes informed by recognizing that it is part of whole body health. That conversation with a doctor works best when it is specific. Instead of simply saying that sex is not the same, it helps to describe what has actually changed. Is desire lower than before, or is desire still present but the erection is weaker? Is it difficult to get an erection, difficult to maintain one, or both? Did the problem begin gradually over years, or did it seem to appear after a medication change? Are morning erections less frequent? Is fatigue, low mood, numbness, poor sleep, or reduced exercise tolerance part of the picture? These details matter because they help point toward possible causes. Reduced libido may push the clinician to think more carefully about testosterone, depression, stress, or medication effects on interest and motivation. Difficulty maintaining firmness may suggest vascular factors, performance anxiety, or both. Numbness or changes in sensation can raise concern about nerve function, especially in people with diabetes or possible vitamin deficiencies. The more honest and concrete the description, the more useful the medical response can be. One of the most reassuring things patients often learn is that treatment plans are not fixed in stone. A prescription is not a life sentence to one exact drug at one exact dose forever. Medicine is often adjustable. If a blood pressure medication appears to be contributing to sexual side effects, there may be an alternative class that still controls blood pressure effectively with fewer sexual concerns for that individual. If a statin is necessary, but symptoms raise concern about hormone effects or side effects, a different statin, a different dose, or a broader review of cardiovascular risk may be appropriate. If a man taking metformin has symptoms suggesting nerve irritation or fatigue, checking vitamin B12 and correcting a deficiency can be a meaningful step. In some cases, the right solution is not removing the medication but adding support around it. such as treating erectile dysfunction directly while preserving the heart or diabetes treatment that the body still needs. The key is partnership rather than guesswork. This is also the point where lifestyle stops sounding like generic advice and starts looking like a practical medical tool. It is easy for phrases like exercise more, sleep better, or manage stress to sound predictable, but in sexual medicine they are anything but superficial. Erections depend on blood vessel health, hormone balance, insulin sensitivity, emotional regulation, and nerve function, which means daily habits can make a real difference. Regular physical activity improves circulation, helps blood vessels work more efficiently, supports heart health, improves insulin sensitivity, and can raise energy and confidence. It does not require an extreme transformation. Even consistent walking, resistance training a few times a week, and reducing long stretches of inactivity can help. Weight management matters not because of appearance, but because excess body fat is associated with inflammation, lower testosterone, worse blood sugar control, sleep apnea, and vascular strain, all of which can contribute to erectile difficulty. Sleep is another part of this puzzle that is often neglected. Many men are functioning on poor sleep for years and no longer recognize how much it affects desire, mood, hormone regulation, and sexual response. Testosterone is closely tied to healthy sleep, and fragmented sleep can affect arousal, energy, and the body's ability to recover. Sleep apnea deserves particular attention because it is common, underdiagnosed, and strongly linked with erectile dysfunction, cardiovascular disease, and daytime fatigue. A man may think his problem is purely sexual when in reality he is also snoring heavily, waking unrefreshed, and carrying a treatable sleep disorder that is straining the entire system. Addressing that can improve far more than one symptom. Stress deserves just as much respect. Chronic stress does not merely create emotional tension, it changes the body's chemistry. When the mind is continuously operating in a pressured, vigilant state, sexual response often becomes more difficult. Desire can drop, focus can fragment. The body may remain physiologically activated in a way that works against relaxation and arousal. For some men, this creates a cycle in which one episode of erectile difficulty leads to fear of the next one, and that fear itself becomes another contributor. The issue is no longer just blood flow or medication. It becomes anticipation, self-monitoring, pressure, and avoidance. That does not mean the problem is all in the head. It means the brain is one of the organs involved, and emotional state can amplify a physical vulnerability. For some patients, reducing stress through therapy, mindfulness practices, exercise, improved communication, or simply restoring rest and routine can meaningfully improve sexual function. Relationships also matter more than many people admit. Erectile dysfunction often affects two people, even when only one person is experiencing the symptom. Silence can easily fill the room with wrong assumptions. A partner may worry that attraction is gone. The man experiencing the symptom may feel ashamed, defensive, or withdrawn. Both people may stop initiating closeness out of fear of awkwardness or disappointment. This is why practical guidance sometimes includes something as simple and difficult as having a kind, direct conversation. Saying, "I care about us, this has been affecting me, and I want us to deal with it together," can change the emotional atmosphere completely. When couples understand that erectile dysfunction may have medical contributors, the issue often becomes less personal and less blame-filled. Intimacy can then be approached with more patience, flexibility, and teamwork. There is also value in remembering that erectile dysfunction is treatable even when the underlying disease cannot be erased overnight. A man with diabetes does not need perfect blood sugar for a full year before he deserves help. A man with hypertension does not need to fix every cardiovascular risk factor before the topic can be addressed. Doctors have tools. Depending on the individual case, those tools may include medication review, hormone testing, counseling, oral erectile dysfunction treatments, management of sleep disorders, correction of deficiencies, pelvic floor support, cardiovascular evaluation, or referral to a specialist. The important message is that the presence of chronic disease does not eliminate the possibility of improvement. Many men recover function, regain confidence, or find treatments that restore satisfying intimacy, even while continuing to manage other health conditions. At the same time, this topic offers an opportunity that goes beyond sexual performance. Erectile dysfunction can be a turning point. Some men first begin exercising regularly because they are worried about erections. Some finally quit smoking because the problem has become too visible to ignore. Some seek care for diabetes, weight gain, low energy, or depression only after sexual symptoms force the conversation. That does not make the motivation shallow. It makes it human. People change when something personal becomes real. In that sense, erectile dysfunction can sometimes serve as a wake-up call that leads to broader healing. A person may arrive at the doctor's office worried about intimacy and leave with a more complete understanding of heart health, metabolic health, sleep, stress, and long-term prevention. What matters most in the end is rejecting the false belief that a man must choose between staying healthy and preserving his sex life. In many cases, the real goal is to build a treatment plan that protects both. That may require some trial and error. It may involve medication adjustments, lab work, lifestyle changes, direct treatment for erectile dysfunction, or a more careful look at hidden contributors like sleep apnea or stress. It may take patience, but it is absolutely possible to approach the issue intelligently and safely. The right response is not shame, silence, or impulsively stopping medication. It is informed action. And perhaps the most comforting truth is this: erectile dysfunction does not erase masculinity, does not define a relationship, and does not mean the body is broken beyond repair. More often, it is the body asking for attention. It is a signal that something deserves a closer look, whether that is circulation, nerves, hormones, medication effects, emotional strain, or overall health habits. When men respond to that signal with openness instead of avoidance, they give themselves the best chance not only of improving sexual function, but of protecting their future health in a much broader sense. That is why this issue deserves compassion, not embarrassment, and careful medical guidance, not panic. The path forward is rarely about choosing one part of life over another. It is about understanding the whole picture clearly enough to move toward health, intimacy, and confidence at the same time.